Okay, hello everyone. This is Howard Mann. Welcome to the webinar. This week, Seth will start off, so give me a moment to make him presenter.
All right, so this is a gentleman who had, he had an infarct. You could see here that his LAD territory is dramatically hypoperfused, and it's also kind of this abrupt transition from normal thickened myocardium to so large LAD territory infarct. They put in an intra-aortic balloon pump and kind of pushed a little bit too hard, and you can see that there's a nice little pseudoaneurysm in the region where the balloon pump would have been, and you can see there's hematoma surrounding that as well. And this is only the start of the story, so it gets kind of interesting, but I'll just quickly show that. You can see all this subendocardial hypoperfusion here in the LAD territory. So really anterior wall, anterior septal, even going to anterior lateral must have a big LAD, a lot of diags. And as we get towards the apex, circumferential, because most people, the LAD supplies the whole apical segment. Well, depends on the patient's anatomy. Anyways, so then he codes. So they put in a covered stent and he codes, and this is his lungs literally the next day, where, so there they put the stent in. He's got a pneumothorax. He's just got dramatic, secretions. He's secretions in the trachea. They actually have a bronchial blocker because some of this is hemorrhage. They did an angio. They didn't find a cause of bleeding, but this is where it gets a little bit interesting. And let me try to organize these in some sequential. Let's see if I can load these. And why is it asking me that? Study management. Let's see, can I just load them? All right, well, let me just start them one at a time, which may be a little bit of a pain in the ass. So here he is right after he got his covered stent. They put another intra-aortic balloon pump in, and you can see he's developing pretty classic edema. So that's before the diffuse consolidation that we saw. Then this is the next day, where literally very, very rapidly he developed this pretty much white out of the left lung, some areas of sparing, and then pretty extensive edema in the right lung. The pneumos got better. This one is a little bit later that same day. So we're still, but what's amazing is look how rapidly this clears. So here we are the next day. So we went from that CT where basically all his lungs were completely consolidated to that last chest x-ray to this chest x-ray. And then this is now the next day. And what is amazing, so literally, I just never seen in a day and a half lungs go from, so this is he's clearly edematous, but I just never seen lungs go from, from this to basically with a pattern of mildish to moderate edema in 36 hours. I just thought it was really impressive how much of this cleared out. And presumably, the question is then, what is this? Is it just all, it's not gonna be pneumonia. They did put him on ECMO, but also what's interesting, just another thing to point out here, is he has all this non-opacification here now of the LV apex, which you're tempted to call all this thrombus because that's where he had his infarct. Actually, if I didn't put up his abdomen and pelvis CT, now I remember why I actually put it up there. I didn't anonymize it, but on the delayed scan, which we do abdomen and pelvis on, there actually is a little bit of thrombus, but almost all this non-filling is just lack of filling from slow flow from that big LAD territory infarct. But then, going back to the main question, I guess all of this must have just been a combination of fluid and blood for it to go from this to this in like 36 hours. Any other, have you seen lungs clear that quickly?
I've seen opaque lungs like that in patients on ECMO. And typically in that context, when the lungs become white, and they become white very quickly, can become white very quickly, typically it's because they are using very, very small tidal volumes. So they're simply not inflating the lungs. And sometimes, of course, in addition to that, the central airways contain secretions, sometimes the trachea contains secretions. But my interpretation would be is that he had primarily atelectatic but recruitable lung. And maybe your best chance of working that out is to try and find out the tidal volumes they were inflating these lungs with.
Yeah, because he doesn't have, I mean, he doesn't have a lot of
Sensitive.
volume loss here. It's not like the lungs are just, they're completely, they're filled with something. And I don't know, to me, there's not just collapse. I mean, I agree, some of it is definitely going to be atelectatic lung because he's on ECMO. I don't know. I don't know the answer.
Yeah,
So
that
this, okay, that's the ECMO cannula in place then. So this is
in the
the
right
CT time of ECMO. Yeah,
Yeah, this was at ECMO. And but
was-
he was on ECMO even on, I think, was he on ECMO the prior CT? No, but the chest X-ray that had him here, he's also an ECMO at this point in time. No, so yeah, it did occur with ECMO, and I agree that a lot of it is just the lungs not being used. I was just shocked at how clear, how
right.
quickly they cleared. And the
I
other
think
thing they did is I think they, anyways, I was just shocked at how quickly the lungs, this is the next day from those completely consolidated lungs, and now he just looks like he has edema again.
Right.
Um, so
Yeah.
anyways, I just thought that was kind
Yeah.
of cool.
Yeah, one can find sort of descriptions of that or reports of that described in the, if you just do a internet search as the white lungs of ECMO, and then
Yeah,
ideas about why the lungs become white. But I think in substantial number of people, it's just that they ventilate them at very small tidal volumes.
okay. So this is very, nothing special. It's just a very nice example of, there's people who have apical HCM, and there's a small portion of the apex which is spared from that thickening. You can also see there's actually even HCM involving the RV, which is actually not uncommon with the apical variant. So it's actually not uncommon to have some thickening of the RV. But what's interesting is the size of this aneurysm. It's common to see little aneurysms, and I've seen bigger than this. This is one of the meatier apical aneurysms I've seen with a case of apical HCM in a couple of years. And you can see it's quite dyskinetic. It's very thin, and as you would expect, that area enhances quite impressively. Let me see. Hopefully this won't take too long to load up the 3-chamber. The point is, there's also a little tiny thrombus sitting in there. No, don't do this to me, you stupid thing. Let's see. No, it's going to do that. Anyways, I'll just stop it here. I'm sorry, I don't know why it's doing this for me, where it's not just playing the. But you can see there's not only an aneurysm, but there's a thrombus in the aneurysm. And then let me go to the delayed. I need to figure out a better way to show these cases. Then Tara's getting a little bit of a pain in the ass. So here it is. You can see not only that hazy mid-myocardial enhancement you see with the HCM, but here's that pronounced transmural thinning with enhancement of the apex, and there's the thrombus there. And if you want, you can, I don't know if we did any sort of yeah, I mean, we didn't even add some. You can add if you really want to, 600 milliseconds to the time to really bring out the thrombus, because everything else will gray out, but it's pretty clearly thrombus. So nice kind of apical HCM case, pretty classic. And I don't remember what this case. Oh, this is, I think Howard showed a case like this, and I just wanted to show our case that looked very similar. The case where, the limited intimal tear.
Yes.
Where there's this very focal, I just, it's funny, I wrote Dominic Fleischman, I showed him this case, and I said, I really don't like the term limited intimal tear for these. And he's like, no, I understand. It makes it sound worse than it is, or not as bad as it is. But, I kind of asked him, well, why don't you call it focal intimal tear versus limited? Because it's not, it's limited in the sense of the superior to inferior extent, but it's still a bad actor. And you can see here this patient on the non-con, here's the non-con. He's got full-on rupture where there's blood all throughout the mediastinum. There's blood in the pericardium. So this thing has clearly, and he said it's really not rupture, and you can actually see blood along the PA here. He says what it is, and I'll take his word for it because I didn't know this, was that he said the intima is the only portion of the aortic wall that's actually kind of waterproof, that the media and the adventitia don't prevent the leakage of fluid and blood from, they're somewhat porous compared to the intima. So once you break through the intima, that even though there's not a hole in the wall, you can get blood going through the mediastinum, which is true. But when I talked to our surgeon about this case, he actually described there being a defect, a visible defect from looking on the outside in, a visible defect in the wall here. So again, this is just a very similar case to what Howard showed.
Yeah, very.
A few weeks ago with, and this is why they, you hear the word limited, you're like, oh, it's not a big deal, but this is why they had the same kind of outcomes as in their big case series, the same outcomes as standard type A dissections, and the ones in the descending thoracic aorta have same as standard type B dissections, because, and this case kind of nicely illustrates that. And then the case, for me, the case of the year, which I was going to wait to see if Travis got on for this. I was really, I have to say, I toot my horn plenty, but I was really impressed about this. So this was a guy, I was just looking at the study, literally comes across, this was a cancer workup. And you notice the aorta is quite funky. It's aneurysmal, it's got really circumferential wall thickening. There is some atherosclerotic disease, or at least intimal calcification involving the descending thoracic aorta. But if you go to the arch vessels are completely clean, except for maybe the ostium of the left sub here. And I know we don't see the coronaries very well, obviously we don't, but there's no hint of atherosclerotic disease here. And then the portions which we actually do see kind of well, like the RCA here, I mean, they look completely normal. There's no atherosclerotic disease. And then go into the belly.
How old a person is this, Seth?
He's about 65. So go into the belly, and you could see that, again, the circumferential thickening. Here is the iliac, which is pretty much subtotal occluded. There's a little bit of flow through it, but pretty much occluded. But his kidneys are fine. Everything else looks fine. His branch vessels off the aorta look fine. There's nothing there. So then I went back to kind of this and looked at it in kind of a standard aortic plane, which I'm not doing a good job of right now. And just kind of looked at it, and it kind of this very dilated saccular ascending, which is irregular but kind of tapers down as you get. And I just said, man, I wonder if he has syphilis. And sure enough, I pulled up and I just typed syphilis into his, Radiant thing, and he has long-standing neurosyphilis, and yeah, he's got
Well,
long-standing neurosyphilis and has had positive neurosyphilis for many decades. So I'm presuming this is a syphilitic aortitis.
whoa.
So I've never seen a case.
Yeah.
This guy is from Mexico, and yeah, I so I patted myself on the back after this one because I'm like, that was because I was going to call it a large vessel vasculitis, but I didn't like the fact that nothing outside the aorta seemed to be involved. But anyways,
The classic, Seth, is for the ascending aorta to be involved, to have calcification that's out of proportion to the calcification you see in descending aorta, which is where atherosclerosis goes.
right.
And then also have the right brachiocephalic artery as part of the aneurysm. So had this continued up into the right brachiocephalic artery, it would have been slam dunk classic case.
Well, the right brachiocephalic is a little, yeah. Yeah, it's not that meaty, but
Yeah.
I mean, the other findings you discussed, the descending thoracic aorta has, little flex, but nothing like the ascending, which isn't that bad, but more circumferential.
Yeah.
And yeah, when I just Googled syphilitic aortitis CT, I have to say this case would have fit right in with every other case that's available online. So I don't know.
Charlie Hibbs wrote an article about this back in the 70s, and he's looked at cases that had ascending aortic calcification, and in that era, about a quarter of them were syphilis.
Really?
So the idea is, these days there's much less syphilis out there that goes on to these advanced stages. We're out of the World War II and Korean War era. And so these days, of course, it's going to be atherosclerosis, even though atherosclerosis does not choose the ascending aorta in particular. These days, it would be a higher percentage of those cases than the 3/4 back in the 70s. But that was a substantial number to have a quarter of the cases turn out to be syphilis with ascending calcification.
And his syphilis, I don't even understand it. His syphilis, so this is, even though he has no neurosyphilis, from 10/14, so that's 2 weeks ago, it's still positive, his syphilis screen. And they've gotten syphilis out of his CSF and all that good stuff. So
wow.
I don't know.
Wow. That's unusual.
Yeah, I've never seen the case. So I was really, I was happy it popped into my mind, and I'm like, let me just type this in. And sure enough, I was like, no way. I actually, believe it or not, I remember David showing a case a couple of years ago, and it kind of had this bulbous, weird morphology, and I just, yeah.
It's because you think the worst of people that you say, oh, this has got to be an STD, right?
No, it's funny, I've never once said to myself, oh, this looks like a case of syphilitic aortitis. I'd never even come into my mind until this case, and I don't know why. I think it was just had the right amount of caffeine in me, and that it just popped in. I mean, I'm sure every other day it would have never even crossed my mind.
Cool.
But, yeah, so those are my cases.
Excellent. Thank you. Okay, let me make myself presenter and show you my case. So before I show you the images, this is a patient that came to us from another institution, and as best I could tell from the outside records, he had for quite some time unexplained dyspnea on exertion, was subsequently diagnosed with pulmonary hypertension. And of course, they evaluated him for the usual things like interstitial lung disease. He did have a perfusion scan at one point. I don't have that to look at, but it showed defects. And I guess the defects were of a sufficient size in the lungs that they thought about the possibility of CTEPH as a potential diagnosis. So with that as a prelude to this patient, I'll show you this. Now, the quality of this outside image isn't that great, but if those of you looking at this in real time perceive maybe reticulation, that something's wrong with the lungs, you're right. So this goes back to December last year. Then he has a CT in February. And I'll make this big. Starting at the top there, we already see very thickened interlobular septa. As we go further down, we begin to see other signs of interstitial lung edema. For trainees watching this video, this is a really nice example here of peribronchial fluid cuffs. And then in relation to the interlobar fissures, subvisceral pleural interstitial edema. So he's got florid interstitial edema in his lungs. Septal lines, of course, are very extensive there. And again, a very nice demonstration down here of peribronchial fluid cuffs. So he has florid interstitial edema. Let's just look at his heart in general. Scrolling through this, yes, the main pulmonary artery is a bit enlarged, and I'll show you some parameters from a right heart cath in a moment. A few lymph nodes that are either normal in size and clustered together or slightly enlarged, but not particularly impressive lymph node enlargement. And the cardiac chambers look okay. So that is in February. Chest radiography in May shows persistent findings of lung edema. CT in May, same findings, florid interstitial lung edema like I showed you before. Let me just make sure I've got the right dates. Yep. So florid, persistent and florid interstitial lung edema. And in fact, down here in a few regions, we're beginning to see opacification of portions of lobules with ground glass opacity, so consistent with alveolar edema as well. Let's go forward in time to CT-PA type exam in July. A notable negative finding is no findings of CTEPH, persistent florid interstitial lung edema, as well as foci of alveolar edema. I would attribute what we see here presumably to lymphoid tissue that's waterlogged, some edematous lymphoid tissue. So the dominant finding is florid interstitial lung edema over many months. And he ultimately went to transplantation. So before I show you the report of that, any thoughts for his?
Can you go back to the lung windows? Sorry, I was just
Sure.
pulling up another case.
Of the most recent, say the lung windows of here is May.
I mean, whenever I see this, and for the normal left atrium, I'm, thinking PVOD and along that spectrum, especially with the lymphadenopathy and the history of pulmonary hypertension.
Yes, exactly. Exactly.
That's what gets me going. Yep.
Certainly in that context, one should try to look in between the edematous lung and in between the septal lines for any hint of ground glass opacity, particularly centrilobular nodules that may potentially represent in the same lungs, of course, pulmonary capillary hemangiomatosis. But I don't see this in this patient. It's just persistent florid interstitial edema. So I'll leave that up. And here I'll show you that, I'll make this up, that we can see pulmonary hypertension, wedge 13 millimeters of mercury, increased pulmonary vascular resistance is present. And here is a nice description of the findings in the lungs of PVOD. So notably, dilated pleural subpleural vessels, thickening of interlobular septa, lymphatics noted to be dilated within septa, some alteration of pulmonary veins, suggesting that they've previously sclerosed or thrombosed, proliferation of capillaries, PCH, collections of hemosiderin-laden macrophages, which one often sees apparently with PVOD. So a very nice correlation between at least this description of the findings in the explanted lungs and the diagnosis of PVOD. Absolutely. So for those of you that want to look and read and hear a really nice description of the pathologic findings in PVOD and PCH, go to this Fix Patterns YouTube channel. You can find that on YouTube. And these are pulmonary pathologists, really great pulmonary pathologists from the Mayo in Scottsdale that did this whole series of talks, a long series of talks, really great, on pulmonary diseases. And their description of findings in PCH, PVOD in these two talks here are really excellent to help you understand why we see what we do in the pathology reports. So I really recommend that one. Those are really great. And all their talks and all these IRDs are really good, as you can see here. All right. Let me go out of that and see if Travis is on here.
I have another case I can show too if he's not.
Okay. Let me see if I can get this thing up here. Is that you? Let me see. Okay, should get something in a moment.
Yeah, this is a case I sent to a bunch of you guys, but that we're still kind of debating what it is. So this patient has had these nodules now for many years, slowly growing. Like for instance, this nodule, which I can't remember how large it is now, but it was like 1.4 centimeters in like 2014, and now it's, oops, that's not a length marker. And now I think it's 3 centimeters. Anyways, very slowly growing. And one of the conspicuous findings is the findings of small airways disease, both large and small airways disease. These airways aren't normal. Some of them bronchiectatic. They have very kind of corrugated appearance. And then we have the mosaicism. And so actually when I read this study back in, I think 2018 or 2019, I kind of hedged and hawed. I didn't know what it was. And I said, it could be Dipnic. The patient's refusing a biopsy. And I showed the people, I just didn't like it for Dipnic. And now, I mean, it's still the best thing I have on the differential, because a lot of these nodules are very peribronchovascular. You can kind of see them going along the peribronchovascular interstitium. There are just so many. I mean, the cases of Dipnic I've seen, there's a few scattered nodules, but you can see here, look, there's kind of nodularity along the peribronchovascular interstitium. And, I think I showed this to the group. I kind of sent it out as a consult, and I think everyone wasn't sure, but a lot of people said they thought it was probably going to be Dipnic because of the nodules and mosaicism. But the other thing that was atypical is that she developed asthma in her 20s. So she wasn't the 50-year-old asthmatic, adult onset asthma. I guess 20s is still, I guess, adult, but it's usually not the classic 50-year-old. And yeah, I still not sure what it is.
Couple of ideas. This could be an atypical mycobacterial infection. This could be something along the lines of MAI, and you can get slow-growing nodules with that.
But it's like they're all all
this
complete
is some sort of lymphoid infiltration in the lungs, something along the lines of follicular bronchiolitis or low-grade lymphoma. Jeff has shown a few cases of malt lymphomas lately. This wouldn't be bad pattern for some sort of lymphocyte infiltration of the lung. You know,
Yeah, so we talked about potentially, like Jeff brought up, you know, and it popped to my mind, lymphomatoid granulomatosis, but those nodules are usually much more bizarre, ugly looking. We thought about, you know, he talked about, I agree, some sort of lymphoma, lymphomatous process. And, you know, the reason I didn't love infection was, even chronic infection, was that the nodules were all in the same exact distribution since 2014, and they were just slowly growing. So it's not like they were disappearing in some places and popping up in others. But yeah, so we were kind of between the, you know, my current report, I actually said maybe some low grade lymphoma or
Yeah.
DIPNIC and recommend biopsy, but they're not going to, the patient's just refusing biopsy because he thinks the biopsy is going to spread her cancer. So I don't think we'll ever get an answer. But I do like something lymphoid as well, given the involvement of the peribronchivascular interstitium.
Yeah.
But it's been going on for a long time, huh? Yeah. Interesting.
Anyways.
Yeah. Great. Well, I think Travis has not been able to make it. So a half hour this time, guys.
Yeah, we'll end early.
Yep. Okay. Thanks, everyone.
Thank you.
See you next time. Cheers, everyone. Bye.
Bye.